एक सेकंड यार.
So, good morning, respected faculty and dear delegates. On this fine Sunday morning, I welcome you all once again. I request Dr. Dinesh Goyal to please start the proceedings.
Okay. Good morning, sir, and warm welcome on the behalf of IIP Delhi office. And this is the second session in series of eGastro module. I welcome you, Dr. M.S. Viswanathan, and Chairperson Dr. Alak. And today's session is going to be very, very, very
Dr.
good.
Anurag also, as Chairperson.
Yes, yes. Dr. Anurag also. And thanks for joining and sparing time on the Sunday morning. And congratulations to Dr. Meena also for conducting very nicely. And without wasting much time, please start the session.
So we welcome Dr. Rosie Olak. She is the head of the department at Government Medical College, Chandigarh, and she is interested in neurology. And we also welcome Dr. Anurag Agarwal. He is Central IIP Joint Secretary Liaison from Delhi. And I request Dr. Shyam Meena to please introduce the speaker and start.
Very good morning to all. I would like to first to thanks to IIP Delhi office bearer, or President Dr. Ajay Kumar Gupta sir, or Dynamic Secretary dear Dr. Dinesh Goyal, and all the office and executive board member. I would like to thanks to all CIP office bearer as well as executive board members, because that thoughts come from behind the that thought for the academic increment that come from their mind. And now in continuation of upgradation of the academic knowledge of our colleagues or practitioners or students or residents, in continuation of that, as a being I'm qualified gastroenterologist, my moral responsibility to improve the GI care for our beloved children of our countries. For that, we start this master classes, and now today's the second session of the master classes. In today's topic that assigned to Dr. M.S. Viswanathan. Dr. Viswanathan is well-known personality in pediatric gastroenterology field, and not only for India, entire worldwide. Is a qualified gastroenterologist working as a senior gastroenterologist in the Apollo Hospital, Chennai. He did the various fellowship as well as training program before starting their career. The last is get the training from the Barringham Children Hospital and Skins Hospital, London, and the various awarded get the award, like the last award is fellowship Royal Challenge of the Pediatric and Child Health UK. And is Dr. Nathan is held the various important post in not only IEP Delhi, IEP Central IEP, as well as also for the Indian Society of Pediatric Gastroenterologists. He earlier held the post as the Vice President IEP Tamil Nadu in 2026. As recently successfully completed a tenure as a National Secretary of Indian Society of Pediatric Gastroenterology, Hepatology and Nutrition. So without wasting much more time, I'm just invite the Dr. Viswanathan to
Meena,
the token.
let
Before
us
that, I
ask
request
chairpersons to
Dr.
say a
Ajay.
few words.
Dr. Ajay, kindly.
Yeah. I request Dr. Rosie, ma'am, and Dr. Anurag to say a few words before we start.
A very good morning and greetings from Chandigarh. Thank you, IIP Delhi, for having me here. And I think it's a very good initiative you started, and we were just discussing that even the attendees are in good number, which means it's a relevant topics you are taking up. And today's topic is really one of the most common encountered pediatric emergencies which we see, the two case scenarios. And I hope and wish Dr. M.S. Viswanathan will take us through almost all the practical dilemmas which we have in actually dealing with these two, GI, foreign body and corrosive injury. Thank you.
Dr. Anurag.
Welcome you all. Yeah, good morning, friends. And I think IIP Delhi is doing a great job in promoting e-learning. And we have done multiple modules. Dr. Ajay, which module is this? 7th or 8th?
7th.
Over last 3 years? 7th, huh?
This one is the 7th.
Dr. Ajay has been our flag bearer, and he has been very active in OS and team IIP Delhi, including Dr. Dinesh Goyal. for a very successful module. And to the participants, learning is a never-ending process. Keep learning, enjoy the module, ask questions, be inquisitive, and these modules. With these words, I request the speaker to continue with the session. Thank you so much. Thank you.
Thank you, Dr. Anurag and Dr. Rosie. Dr. Viswanathan, sir, I request you to please start sharing this.
Just 1 second, please. 1 second.
Sure, sir.
Sorry, there is some disruption of the power here. Sorry about that. And let me just see whether I can connect it now.
I request to all delegates kindly put your queries on question answering session.
You see my slide?
Yes, sir. Please make it full screen.
Thank you. Thank you. Good morning. Sorry about that. There's a slight disruption in the power supply here. Good morning, everyone. Thank you, IAP Delhi team and Dr. Ajay Gupta, Dr. Dinesh Goyal, and the chairpersons today, Dr. Anurag Agarwal and Dr. Ruzi Aluka, and of course the coordinators, Dr. Shyam Meena and Dr. Karnesh, and also in absentia, Treasurer Delhi, IAP Treasurer Dr. Alok Bandari and Vice President North Zone, Dr. Devendra Sari. Thank you, Dr. The IAP Delhi team for inviting me to do this talk. I'll be talking on the GI foreign body and corrosive injury. My talk will be focused more on what the pediatrician has to do. I will be not discussing in detail about what the gastroenterologists do, but I will give a flavor of what we do also. And so let me start with the case scenario. The case scenario will be, a child who is 3-year-old who was brought to the emergency department, the difficulty in swallowing. 1 second. Let me just name the screen. 1 second. Are you able to see my slide?
No.
I got disconnected. Once again, sorry about that. 1 second, I'll be doing this soon. Can you see that now? No issues, I hope.
Yes.
Thank you.
It's
Sorry
good.
Yeah. So this child was born with difficulty in swallowing and drooling of saliva and without any respiratory issues. Parents said the child was playing with a small toy with button battery, and they found the toy to be open and there was no bat. But there were also some coins found around the same area. On examination, the child was clinically stable in the sense that the vitals are okay with the saturation around 98% on air, but a little bit cranky. On arrival, the family have brought an X-ray chest with the AP and lateral view. So my discussion will be about how will you differentiate these two foreign bodies, because we do not know whether the child has taken the coin or child has taken a button battery. But why is it important? It's also important to know which foreign body has gone in. Otherwise, there is a way, because it all depends upon the type of foreign body. We decide about the emergency referral and emergency removal, etc. And also to know where exactly the foreign body is in the GIT. So you see the coin here and the button battery here. I actually displays on the right hand side. You see the disc battery on the right, which is basically has got the two halo, and I think you will be able to see on the X-ray also the double ring or the halo sign. And in the coin, basically it's a homogeneous shadow. So when we take an X-ray, we always tell people, to look at these things and also try to take a lateral view also. In the lateral view, you'll be able to see the two-step pattern. You could appreciate that on this side. On the left-hand side, the two-step pattern. On the right-hand side, you see the coronal plane, the double ring pattern. Basically, the halo. You could appreciate that. And if you go to this, basically when we do an X-ray, why we ask people to do an X-ray of AP and as well as lateral. Are you able to hear me? And am I clear, Dr. Shyam? Am I clear?
Yes, yes, yes.
Thank you, thank you. So you'll be able to see the X-ray, and basically the idea of taking a coronal and the lateral to decide whether the foreign body is in the GIT or whether it's in the respiratory tract. So basically, on the frontal view, the coins in the esophagus are round in appearance, whereas if the coin in the trachea is usually seen on end and or linear in shape. So you could appreciate that in these two X-rays, the one above, one below, and on the frontal view, which is the AP view, the coronal view, you can see this point, if as it is in the GIT, it will be in a round appearance. Whereas if it is in the respiratory tract, the trachea, you see as an end-on view as a linear in shape. So that's the reason why we suggest to take an AP and lateral, and also include the neck also. And preferably in smaller children, you'll be able to include the abdomen. Whereas, whereas if you are doing it in a bit of larger child, try to have at least the upper aspect of the abdomen, particularly the diaphragm, try to include it. So, okay, the child is coming to you, as an OP or in emergency department. So first of all, I'm pretty sure parents will be very, very anxious, but we as a pediatricians, we have to be, we'll be able to cope with this anxiety. So we try to get information about the nature and the size of the foreign body. Now, probably, if you ask the history, the people, you may get about a possible twin object also sometimes, and that is the reason why it's very important to take an X-ray. And because I remember one of my patient who has taken button battery and has come to me. And then I was trying to do an X-ray to locate the foreign body, but I was able to see two button batteries, one in the esophagus, the GIT, and one in the lower down in the pelvis. I was asking, well, did you know this, the child, there is another foreign body there? The mummy was saying that she was not sure about that. Then I was asking the question, basically they own a toy shop. And then this child was playing in the shop for the 1 or 2 days, as because of school leave or whatever it is. And then probably mummy is saying, oh, you might have taken one before. So that sometimes you could have the surprises also. Then I have to tell them about that, why there is a necessity to have a safe toys in the shop. Just the child playing in the toy shop itself, has taken 2 foreign bodies in a matter of 24 to 48 hours. I told them that they imagine the problem that could happen to the public, whomever they are selling the toys. So that's very important that they get the right, the very safe sort of toys to make sure it's secure for the children not to access the batteries. So, and it's very important to take an X-ray before, an endoscopy or even before you refer. So inquire about the exact time of injection and last meal. And this will, for 2 reasons. One is, it also helps the anesthetist, whether when they can give the anesthesia. And also it helps us, for example, in a child with the button battery injection, it's very important to know the duration, when was the foreign body was taken. Because then we have to make a quick decision about when to remove this, and also depending upon the site of the foreign body. I will discuss about in the next few slides. So collect information about any existing diseases which may represent the critical factors for the impact of foreign body. For example, if there was a previous history of corrosive ingestion, these children are prone for stricture. So there is also a possibility of that the foreign body could be impacted. Although if there's any history of previous surgeries, like for a tracheoesophageal atresia or also the fistulas, if they had a surgery, again, these children are more prone for stricture. And again, the foreign body could be impacted. And also it helps the endoscopist to be aware of these issues when they try to remove the foreign body. So it's very important to know the previous history also. And as I mentioned already, we have to take an X-ray. And sometimes you may not have an access to the pediatric gastroenterologist, but you can always call them before you refer in this era. You can always share the picture on the WhatsApp. So they will be able to give an advice what to do and how to proceed. So all foreign body injections, one have to be, and always treat with like an emergency. And unless if you're very sure, the child is extremely stable and this is unlikely to create problem. So the common sites of foreign body impaction, right at the esophageal sphincter, and then at the level of the aortic arch, because that area, because of this indentation of the aorta, the area is slightly narrow there. And of course, the gastroesophageal junction, And the next area will be pylorus. And sometimes D1, D2 area, they get impacted. And then lower down in the anus rectum, sometimes it could be have. And most important area will be ileocecal area. Usually when the foreign body passes the duodenum D2 area, it usually goes through the small bowel, unless it's a foreign body or a sharp, it's the sharp foreign body or multiple magnets. And then sometimes there may be a possibility of foreign bodies getting impacted at the ileocecal area, the valve, because that is a smaller area again. And that's one thing we need to keep in mind. So these are the common sites of foreign body impaction. So I'm just going to talk a little more in detail about button battery. The reason I'm going to talk a bit more about button battery across the globe, not only in the Western world, also in India, the incidence of button battery ingestion has increased dramatically over the last 10 to 15 years. And some studies have quoted even up to 25% of the foreign body injections in their series were found to be button battery injection, which is quite a significant number. The button batteries, why it is important to deal with emergency is, it has got multiple way of, injuring the GI tract. One is, of course, the pressure itself, the pressure necrosis. Second is the chemical content, which will behave like a corrosive. And that will again behave like a corrosive injury to the GIT. And the most important thing is electrical discharge. The button battery is there. The human tissue will be a conductor of the circuit between the two poles, and hence the leakage, the electrolysis of these button batteries, which could be a zinc battery or lithium battery or anything else, can create a significant problem. And other thing is, why? Because the risk of complications is very high with button batteries. There are 3 or 4 reasons why it is high. I mentioned to you, and particularly studies have reported if the button battery is in the esophagus, people have reported within 2 to 3 hours of significant necrosis. And hence, if there is history of foreign body and you are taking an X-ray, if the button battery is in the esophagus, it's an emergency referral, because it is better to be repeated within as soon as possible. I will say even 3 or 4 hours. Preferably within 12 hours, one has to remove. And definitely, ideally, if it is in the esophagus, we better to remove as soon as possible. And because of this, I mentioned about the mechanism of injury. And because of that, because of the proximity to the many areas, anteriorly, you have the respiratory tract. And then you can also have the thyroid arteries, you have the aorta there. They could result in the necrosis can lead to the fistula, can lead to bleeding there. And it can also result in mediastinitis. And if it is very well above around the upper airway, upper esophageal area, that can result in vocal cord paralysis. And the late sequelae will be stricture. People have also reported, and rupture of the anterior thyroid artery when the button battery was well above the level of hypopharynx area. And that is the reason the prompt removal is very, very important in button battery ingestion. And for that matter, any foreign body which is getting stuck up in esophagus. For example, coin, I'll come back to that. Button battery, as I mentioned to you, liquefaction necrosis happen due to formation of hydroxide radicals. The necrosis of the lamina propria can happen within 15 minutes and extend to the outer layer within 30 minutes. Some studies have reported stricture even within 2 hours. I mentioned this earlier. This is many ways it can damage the esophageal mucosa and, of course, the stomach as well. We had one child who had got 3 button battery injection in the stomach. You could see that, basically, the guidelines which are there from the European Society or the North American Society, if you look at them very carefully, those sort of countries, the healthcare is mainly provided by the government, which is the public sector. So they always want to prioritize which patients they have to deal with first. And that is the reason, when they form the guideline, I'd say Indian setup, we need to think very carefully. In our setup, it's 75 to 80%, the healthcare is delivered by the private sector. The government sector doing very well, but unfortunately, our government sector could not cater to the huge population we have in our country. And they say that if the button battery in the stomach, you can wait 12 hours, 24 hours, unless there is an history of other metallic body ingestion like magnet, or whether there's a significant symptoms, etc. But my suggestion, my personal experience, and also talking to my colleagues, even within the stomach, the injury can be there within 6 to 12 hours. So ideally, if you have a foreign body or particularly the button battery sticking in the magnet, again try to remove, but not very urgent as like in an esophageal button battery. But ideally to try to remove within 12 to 24 hours. That will be a safe way to do that. So, and again, the complications are there. I have seen significant gastric corrosion within 4 to 6 hours of a one button battery being in the stomach. So what the pediatricians could do, before I just talk about this slide, I want to be very careful to know this one. This is just one of the things you can do, but the important thing is an immediate referral to the pediatric gastroenterologist, because some of my colleagues do not agree with giving this honey because they fear that there is a delay in referral. So, but however, if your child is a bit far away, from the referring to a pediatric gastroenterologist or those who could deal with the pediatric endoscopy, while the child is stable, if there is no airway issues, if there is no such a suspected perforation or bleeding or any complication, and it is within 12 hours, and you are expecting the child to reach the referral center within 12 hours period, you could try and give honey. And it's usually for more than 1 year, not less than 1 year, because of still the risk of infant botulism. How much you give? You can give 2 teaspoons, which is 10 ml by mouth every 10 minutes for up to 6 doses. Honey is administered, to coat the battery and prevent the local generation of hydroxide, as I mentioned earlier, neutralizes the battery alkali. And importantly, sucralfate also can be given. Both sucralfate on honey or weak acids, thereby they could potentially neutralize the hydroxide which is generated by the battery, which is mainly alkali batteries. So as I mentioned earlier, I want to re-emphasize again, honey is not a substitute for immediate removal. Even if you are trying to give honey, start the referral process and get the ambulance ready, please. And this is the most important point I would like to state there, because we do not want the children to stay just because they are having the honey, because the injury process continues and the child is at the risk of having significant complication. So I mentioned briefly about I did discuss in detail about the button batteries. Because of lack of time, I won't be discussing about every foreign body, but I'm going to tell you what to do. If any foreign body in the esophagus, which means ideally the esophagus has got good peristalsis, the once anything goes in, it has to go down to the stomach in few minutes to, not longer, it don't take longer time. But if it is in the esophagus, you have to remove within 2 hours, as I mentioned earlier, particularly if it's a button battery or a sharp foreign body or any symptomatic foreign body. The symptom is happening because the foreign body is getting impacted somewhere in the esophagus. As I mentioned earlier, there are many sites of impaction I mentioned earlier. Urgent within 24 hours if the coins or it is a smooth foreign body. But if it's still in the esophagus or the coins in the esophagus, if they are not going to go away to 24 hours, it's going to be really a problem. So it's better that we remove them again if it is in the esophagus. Foreign bodies in the stomach, as I mentioned earlier, it is better to remove the foreign bodies, just sharp foreign bodies or button batteries again within 24 hours. You don't have to go and refer immediately, but ideally refer them so that the pediatric endoscopist, anesthetists keep themselves ready to remove within 24 hours. And any large, even if it's a blunt object, they're large in size, more than 2 centimeters in diameter or more than 5 centimeters in length. Some societies I mentioned is more than 2.5 centimeters in diameter or more than 6 centimeters in length. But if it is less than 5 years, take the lower range, like the 2 centimeter diameter, more than 5 centimeters in length. If it is slightly older children, you could probably, take this larger range of 2.5 centimeter diameter or 6 centimeters in length. any foreign body which has been retained in the stomach for more than 1 week. There has been a suggestion earlier, you can keep waiting for a few weeks. I do not agree with this one because I've recently seen a child from Andaman Nicobar who has had ingestion of a foreign body. But the child had kept on having X-rays. Nearly 10 to 12 X-rays has been done over a period of 8 to 10 weeks. But the child came to me, well, the foreign body is there, it's not crossing your upper GI tract in 1 week. It's unlikely to cross. In fact, some studies have said that if it is not crossing in 48 to 78 hours, don't wait longer. But however, for the benefit of the doubt, if you can wait longer for 1 week, not more than that. But however, in this modern era, in this medical legal era, where you have the specialist available, all the tier 1 cities and many of the tier 2 cities, it's always better you have a discussion with the pediatric gastroenterologist or those who could offer the safe pediatric endoscopy. Talk to them, make a decision, and document in the notes and document and tell this very clearly, communicate with the family. Because I have had patients who will come and tell me that, sir, if that pediatrician have referred early, I would have come early. So do not put yourself in such a difficult situation because they will say to you, well, if you are referred to me, I would have gone there, I would have done it, get it done. Don't worry about the cost. It's as a pediatrician, your duty is to explain to them, you give the suggestion, and you tell them, what is the pros and cons, and let them make a decision. That's very important in this medical legal era. Document and get it signed by the parents in your notes also. This has been explained. It's my decision, whatever it is. You get them signed in your notes, in your medical notes itself. So they will sign that area. That's very important. This particular patient whom I'm talking to you had actually a small coin, but it got impacted D1 side. It's not going from D1 to D2 for 8 weeks period. So when I was trying to remove it, there was a significant erosion there. So it's always better in this era to refer them, or at least to get an opinion over the phone. And also, we do not want our parents are going to work. They are not going to sit at home to keep observing the foreign body in the stools every day. That is not going to be possible also. And this is again in a nutshell about the various foreign bodies I mentioned: esophagus, stomach, and duodenum. This batteries I mentioned already to you. I mentioned to you any sharp foreign body objects anywhere in the GIT, again is an emergency. Blunt foreign objects, I mentioned to you about that. Magnets, particularly if it's more than one magnet, or if it's one magnet, any metallic objects like a button battery, an urgent removal. Because if there are multiple magnets or a magnet is another metal, it's going to have this attraction towards each other. So what will happen? The tissue will get impacted between that, and that will lead to necrosis and fistula. That's very important. Again, food bolus itself is a foreign body. One need to be aware of this one. I'm just mentioning this briefly. In countries like, not even in our country, particularly where there is a previous history of surgery or a condition called esophagitis, the food could get impacted. Again, that will become an emergency. So do's and don'ts from the pediatrician side: advise parents to keep the child nil by mouth till further action. Always take the opinion of the pediatric gastroenterologist, and please do do an X-ray of neck and chest, including this AP and lateral, and abdomen and pelvis preferably. One important thing is, do not give bananas or any laxatives you're going to refer, because I know I have had children, a patient whom I took an X-ray just before doing an endoscopy. It was definitely the foreign body was in the fundus. I could see, but when I went in, I couldn't see the foreign body. What I could see only a banana. I was peeling the banana with my forceps and putting the saline irrigation. The coin is well inside the banana, so it will delay the process, and also it will delay the anesthetist. But most of the places, the anesthetist, we tell the anesthetist not to delay. We ask him to secure the airway with ET tube. But it's ideally, better not to give any sort of this, banana or anything orally, so that it will make the procedure a bit more, easier, and it also helps the anesthetist also. Do not induce vomiting; it's not going to be of any help. So red flags I mentioned earlier: any signs of respiratory compromise, near complete esophageal obstruction, respiratory distress, stridor, drooling of saliva, or the child is toxic. Or I mentioned about the button battery ingestion. I mentioned about the short objects. I mentioned about the long objects. multiple magnets, and I mentioned about any signs of inflammation, intestinal obstruction, when we need to involve the surgeons. So I'm in discuss about the foreign body. I go into the next scenario. I had a call from the pediatrician in my nearby district from Chennai. 2 hours ago, a 3-year-old child accidentally has swallowed bleaching liquid used for cleaning floor, which was kept in a Sprite bottle. Should I place an NG tube and give a gastric wash before referral is a question by the pediatrician. We'll discuss about that. Before I go and discuss anything, it's very important. One, we need to be aware of this important thing. We have to give the anticipatory guidance. This is what is very important for me in both the foreign body injection and corrosives. Keeping the corrosive in an attractive bottle like the carbonated drinks, and that too in a fridge. Now, in summer, the children are so thirsty, they will go inside, they open the fridge, they take it. That's it. It's really a bad thing from the part of the parents. We had one patient who was just literally done like that. So that is the reason why you want to avoid those kind of things. Is anticipated guidance is very important. Corrosives, it could be acid and alkali, which basically anything which is going to corrode the GI tract. And most parts of the world, alkaline injections are more common. In India and Southeast Asia, acid injections, particularly those who are using toilet cleaners or battery fluids, are much more common. But having said that, we know that we are getting westernized in many aspects. We do have most of these products which are being used in Western world. So equally, both acids and alkali injections are common nowadays in our country. So broadly differentiating them, alkali agents, are there in drain openers, oven cleaners, household cleaners, bleach products, dishwashing detergents. Many of them has got sodium hydroxide hypochlorite as the base. Some of them have got ammonium hydroxide and ammonium chloride, and bleach products do have hydrogen peroxide also, and sodium silicate and carbonate present dishwashing detergents. Acidic agents, toilet bowl cleaners have got hydrochloric and phosphoric acid. Metal cleaners have got hydrochloric acid. Antitrust product has got sulfuric acid along with hydrochloric acid. Battery fluids have got sulfuric acid. Jewelry has got nitric acid. As most importantly, it's also important, it will be useful for you to get a history of the father's occupation. For example, a goldsmith may store, the aqua regia. This aqua regia, going back to chemistry, is a combination of this hydrochloric acid and nitric acid. We had patients who have swallowed that. So an idea of an occupation of this parent will give an idea of the possible corrosive the child has taken. Nowadays, you'll definitely able to get history. If not, you can ask them to show the WhatsApp picture they have taken, or at least you can show the WhatsApp images, whatever you have. You can ask them to identify the product, both in foreign bodies and in corrosives. It's easy nowadays to get an idea what's going on. So alkali, remember, it is it's a no irritation to oral cavity. Because of that, this large volume is getting ingested, and it's thicker. Because of thicker, there is a large exposure to esophagus. Stomach is less prone to injury. And remember, alkali has got L in it, the letter L, so it results in liquefacting necrosis. Acid has got the letter C in it, so it results in coagulating necrosis. It's easy to remember. And because it is, oral mucosa is getting involved more, and it's that the small volume will be ingested, and this last viscosity, so it travels faster through the esophagus into the stomach, and because of that, the stomach gets, more problematic. The injury will be more problematic stomach, and they could have pylorospasm and pyloric strictures. So I just want to briefly mention about this, particularly about this corrosive paraquat. This is a herbicide or pesticide which is being used by the farmers. This is commonly being used in South India. I hope that is the case also there in many parts of India. The reason for me mention this particular product is, it not only damages GIT, it damages the multi other organs also. And it's available in many forms, many concentrations. So it's very important to know this one. It results in the reduction of the NADH to NADPH. And then it is increased production of superoxide, that is free radicals, because of the multi-organ dysfunction. It's very important to identify these products early. And because at bedside test, you can do the urine diet test, and it will be able to tell you the ingestion of this particular corrosives. If you know this, if you identify this early, apart from taking care of GIT, you need to be aware of this particular products can result in a lung fibrosis the long term, particularly in adults they have reported, and in children it's an acute kidney injury. We had one of our patients whom we identified early. We involved the nephrologist early. We identified the renal function, acute AKI. We started everything, the hemodialysis, perfusion, etc. And quickly, we are able to salvage these kidneys for this particular patient, and the child went home easily. Went home very well. And there was no any long-term sequelae when we followed this child for more than 2 years. So it's very important to identify this particular product. So in short, any corrosive, they can result in injuries wherever they are basically being exposed to more. Laryngeal injuries has been found in severe esophageal injuries in 40% of the patients, and few of them required mechanical ventilation. And laryngeal trauma, because they could have breathlessness, strident hoarseness. If anywhere in the esophagus, they can result in pain there, or could be dysphagia there. There could be drooling of saliva. If it in the stomach, they can result in hematemesis, or if there's any perforation, anything like that, they can have significant pain, and they could even have a shock-like picture. One important thing, one message I want to give it today is clinical symptoms do not correlate with the severity of the GI injury. We have seen children without any oral or mucosal lesions, but they did have a significant esophageal GI injury. And that's an important message if I want you to be aware of it. So what do you do from your side? Stabilize, please do stabilize the ABC. Remove the caustic stain clouds, rinse the affected cutaneous area. You can very well give anti-reflux treatment, H2 blockers or PPI. Prevent the vomiting and the feeding, and do not induce vomiting at all. And chest X-ray, ideally try to have a dome of the diaphragm also to be there, so that you could look for any sort of perforation or pulmonary complication. Please refer them early. So the early complications could be depending upon which area has been exposed to more. As I mentioned earlier, could be GI bleeding, could be respiratory issues, could be systemic. One important thing I want to mention is all corrosives have got some sort of chemical in it. So there will be also a systemic component to that, systemic effects to that. So always involve the toxicology or a poison center to deal with that. There are specific things like methylhemoglobinemia can happen in phenol poisoning. That could be a significant DIC or hemolysis, hyperkalemia, metabolic acidosis, shock. So also involve, the emergency physician, the toxicology, or those who deal with the poison very well. So corrosive, the question which was asked to me, whether we can give gastric lavage or emetics. No, it actually damages the esophageal mucosa further while the corrosive is being removed or again vomited. So it's better we advise not to do this. Whether you can give neutralizing agents, people have the tendency to give acid for alkali injection and alkali for acid injection, and it's not advisable. They can result in exothermic reaction, which result in retching and perforation. Charcoal, please do not give it unless you do not like your pediatric gastroenterologist, because the charcoal again is going to actually obscure the vision. When you're doing the endoscopy, it's actually making the endoscopy much more difficult, particularly if there's a charring of the tissue. It confuses us actually. And again, no milk and all. There's no point in giving milk. Again, it's going to delay the procedure and it's not going to be of any use. So nasogastric tube as a therapeutic strategy, we do not recommend for the pediatrician to place it. Theoretically, you could increase the risk of perforation also. But however, after endoscopic assessment, we could use this NG tube to promote enteral feeding so that to prevent the total occlusion of the lumen. So initial management, I mentioned earlier, please do use PPI. We do not recommend to use antibiotic regularly. However, it is indicated if there's a perforation or peritonitis or when there's a concomitant steroid use, which will be decided after endoscopy by the pediatric gastroenterologist. Early referral is very important. I'll tell you why early referral is important. Because after 48 hours to 72 hours, there is an increased risk of perforation because of tissue edema and inflammation. And why we need to do endoscopy? To actually assess the extent of the injury. Then only we will be able to get an idea, to deal with it immediately, and also what is the prognosis in a few weeks' time. We'll be able to get an idea. We try to use the thinner scopes with minimal air insufflation under proper anesthesia. And as I told you earlier, we do not negotiate with beyond a charred esophagus to assess the lower down, because the risk is very high. This is one classification which we use. I just want you to be aware of that. Grade 2B and above, grade 2B particularly, we might consider the steroid, and then not otherwise. But again, this is after assessment only. And grade 2B and above is actually very serious injury. And so the risk of stricture is going to be very high in this particular group of patients. So approaching corrosive injection, perform the physical examination, evaluate for the presence of signs and symptoms, investigate the nature, quantity, physical form, injection pattern. Sometimes it could be, what is the physical form, could be even a powder also. And also try to elicit, whether this is a suicidal or homicidal risk also there. So as I mentioned earlier, please do involve your poison center. Call the pediatric gastroenterologist. If there's a symptomatic children or definite ingestion and this hemodynamically stable, we definitely go ahead with the endoscopy within 24 hours. If it's hemodynamically unstable, if there's evidence of perforation, we delay the endoscopy unless we have a further assessment with further imaging or a pediatric surgeon input as well. The asymptomatic children, and that's very, very uncertain about any sort of ingestion of the amount, then probably you could wait and watch. So prevention is key in both the foreign bodies and the corrosives. And as I mentioned earlier, I always like this anticipatory guidance. The moment they started to have the pincer grasp by 8 months or the 9 months or 10 months, we need to keep advising them when they come for immunization. Should not be kept with food and drinks or in household containers. Child resistant packaging is very important, and we need strict legislation. So to summarize about the corrosive injection, early recognition of airway compromise is very important. Blind nasogastric TB insertion, lavage, emesis, charcoal, and milk are to be avoided. Oral manifestation symptoms do not predict the degree of the esophageal gastric mucosal injury. Upper GI endoscopy is indicated in all children unless there is a risk of perforation or severe hyperpharyngeal injury. It's crucial to assess the severity of mucosal injury very early and to prognosticate strictures. We might consider a contrast study after 3 weeks to look for any strictures, particularly in high-risk group. Legislation is what is more important. So just take a message of both these topics today. Foreign body injection, beware of button batteries, sharp objects, magnets, any foreign body more than 2 to 2.5 centimeter diameter or more than 5 to 6 centimeter length. Early referral, corrosives, both acids and alkalis are equally harmful. Remember the do's and don'ts. Again, early referral. Anticipatory guidance is very important for not only for this, in many areas of pediatrics. Those are my references. And I would like to thank the mentors and patients whom I learned both in India and Chennai as well as in UK. Thank you very much for your patient listening. And that's my contact details. If you have any queries, you can contact me. And thank you again, IAP Delhi team, for the kind invite. And thank you very much.
Thanks a lot, Dr. Viswanathan, for the concise, informative talk. Before taking the question answer, I would like to take the final words from the chairpersons.
I think Dr. Viswanathan has summed up both the issues very well and given us very pragmatic advices on both the issues, especially the button battery, not to follow the guidelines blindly, but be more proactive and to act early. And definitely because the silent period might be causing more corrosive injury rather than actually healing phase, which we think that the child is asymptomatic, wait and watch might help. So that could actually prove counterproductive. And regarding the alkali ingestion, another thing which I really found useful is many a times residents say that the oral cavity is not showing any corrosive injury marks. So probably the child hasn't ingested much and they avoid or they, delay the referral to an endoscopist. So that is another thing I think is important, that for alkali injections, the oral cavity might actually seem totally normal. And for paraquat poisoning, I would like to mention it's a really deadly kind of insecticide. We've lost 20 children in the last 2 years to paraquat poisoning, and nothing actually helps. All we can do is a hemoperfusion if they come early, but nothing truly helps. And the renal failure, mostly they come out of it. But the pulmonary fibrosis, they've been admitted from anywhere from 24 to 48 hours to 3 months with us, and they just keep going downhill. So lung transplant is the last thing. We also tried the antifibrotic latest drugs, perfenadine and all, but nothing helped. It's a complete lethal kind of a poison. So this is one thing somebody's asking a few questions also. We'll take them up if we have time. And lastly, regarding the NG tubes and steroids, both of them to be placed after endoscopy is another important, I think, practical thing which we need to keep in mind. Thank you. Thank you for the very informative talk. We really enjoyed it.
Thank you, ma'am. Thank you.
Thank you, Dr. Rosie.
Thank you, Dr. Viswanathan, sir, for a wonderful presentation. And main thing is we must advocate and advise all the parents visiting us to avoid using these button batteries in keeping them in open or putting some corrosive materials in Pepsi bottles or cold drink bottles because children tend to take these as a curiosity. Thank you.
Uh, Before taking the question answer, as a being pediatrician, I have some queries. Just want to clarify from our expert. Sir, what is the role of the serial X-rays in the case of metallic foreign body? And how frequently we take the call for the X-rays as a being pediatrician?
Yeah, I mean, when you're saying metallic, or I mean, you're talking about sharp objects also. I think, as I mentioned earlier, if it's anywhere in the esophagus, there's no question we are going to remove that. If it's a sharp object, metallic objects in the stomach, particularly if there's another metallic object, it's better to remove it again. But if it is beyond the duodenum, if the child is asymptomatic, probably 12 hours or 24 hours, whatever it is. But again, there is no specific guideline about an X-ray. It all depends upon the symptom. And again, but if the sharp objects, always is better that you involve the pediatric surgeon early. Just keep them informed what they want to do also. Sometimes, imaging wise, even for a foreign body in the esophagus, for example, a button battery or a coin has been there for more than 12 hours, 24 hours, significant symptoms. Sometimes we may ourselves have to do an imaging before actually go and remove the foreign body even in the esophagus. The reason is, if they stayed longer there, the possibility of the complications is very high. I remember even a pediatrician coming to me with their own child who was taken for coin for more than 12 hours. That is only coin, but why did you remove that? But the child has significant drooling as saliva. It's very high there. I was asking, this should not be there.
Dr. Viswanathan, in the short, there no any clear-cut guideline about the frequency of the repetition of the X-rays.
Correct.
But yeah, if what type of the foreign body and nature of the foreign body is we are dealing, that is very important. According to that, we will decide the frequency of the repetition of the X-rays. But even in the X-rays, we can miss the small or radiolucent foreign body. So don't blindly rely on the X-rays as a being pediatrician. Then second, majority of cases we observe as a being gastroenterologist in our setup, that the delayed referral, because in the case of the foreign body, even in the corrosive injection, but in the foreign body, majority of the times as a being pediatrician, they are the wait at least 2-3 days. They assume that might be expelled. So as you nicely cover some of the things like the size, like the nature of the foreign body, on basis of that, we can take the decision immediate referral, or we can wait what type of the foreign body. But does any cutoff or any vague timeline on that situation we can consider that child might be required the endoscopy, or maybe need to refer to pediatric gastroenterology, especially in the corrosive aspect?
In the corrosive?
In the corrosive aspect.
I think corrosives, as I mentioned earlier, if we know the nature of the corrosives, whatever they take, and Dr. Aluka has rightly mentioned about the paraquat. I was thinking only it's more common here. It seems to be much more common there. So I think depending upon the corrosives, if the child is a definite injection of corrosive injection, if the definite injection and the child is stable, the child has to be referred for an assessment. If they are uncertain about injection, they think that the child might have taken, but they say sometimes they say that they're worried, but they don't see any decrease in the quantity of the content or whatever they kept it. Child is very stable, then it probably can.
My question is how long we can consider for the endoscopy after the corrosive injection? Within the 24
I told you, ideally within 24 to 48 hours. The maximum is 72 hours.
Okay.
The earlier is better.
Okay. Then what is the role of the cross-sectional imaging in the foreign bodies? Because I observed a lot of the kids we come to in our center with the cross-sectional images, especially I'm talking about the CT scan. What are the indication as a being pediatrician, our audience should be aware that the sort of the group of the children only require the CT scan or cross-section imaging like the MRI. Otherwise that the X-ray is fair enough.
Absolutely, you're right. As I mentioned earlier, if there's a sharp object, or multiple magnets or more than one metallic objects cross the D2, and if it is lowered down and then there is already symptoms there, then it may be a good idea to do an CT after getting opinion of the pediatric surgeon. Or as I mentioned earlier, if it is very high foreign body, it's delayed presentation, already having significant symptoms, before we do, the pediatric gastroenterologist can decide about it. Otherwise, as you rightly mentioned, more than 95%, 98% of the time, it's X-ray is more than enough.
So for the clear-cut message or audience that the no role of the cross-sectional imaging, especially of the CT scan in the any foreign body or corrosive ingestion. But yeah, there are some subtle features if the child is unexplained hemodynamic instability, that the massive hematemesis in that situation, or maybe have the role to rule out the aortoenteric fistula. In that situation, better to take the call for MRI rather than CT scan. CT only might be contribute if the required the immediate surgical intervention, that is only helped out by the CT, otherwise not required the CT or any other cross-sectional imaging.
One point, Shyam, if it is
Yes.
an MRI, we have to be careful when there is a button battery or something. We should better to avoid MRI. In those metallic objects, button battery,
Yes.
don't do MRI. Don't do
Yes,
MRI. Very
yes,
important.
you rightly said. And uh, just advice to our participant, before taking the call for the X-rays, kindly remove the all wearable removable cloth. Many times jeeps or other ornaments might be interfere with the interpretation of the X-rays. One of the questions from the participant, they said, what about the indication of the endoscopy in the ingestion of the glass of the phone, tempered glass of the cell phone?
Repeat, injection of, I didn't get it.
What does any indication of the endoscopy or how to handle the child come with the ingestion of the pieces of tempered glass of the cell phone?
Oh, I see what you mean. Okay, got it. Most of them, this I think, as you rightly mentioned earlier, you cannot pick this on the X-ray. They won't be visible at all. I think if the child is taken in small particles, I'm sure it will be taken in small particles. First, let us assess the oral mucosa, see if there is any significant injury. Here, you are not going to remove the foreign body, honestly, because they will be in multiple small pieces. We won't be able to remove. Most of the time, the child would have bitten and taken it. But if to assess the injury, but it is symptomatic, there may be an indication for endoscopy. Otherwise, I don't think I would advise straight away for endoscopy for this patient. But however, the symptoms, you have to do that.
Does any role of the metal detector to identify the nature of the foreign body, because that is easily available even in the small town?
It is available, but I don't think I don't think I have ever used it to detect the foreign body before I do that, because for me, endoscopy is two ways. One is diagnostic and therapeutic. Even if I'm going to use a metal, I'm not an expert in using metal, and that's not a therapeutic process. So it's not going to be any role for me.
So that means that don't waste the time to unnecessary. Just refer to pediatric gastroenterologist for the removal of the such a foreign bodies. My questions to Dr. Rossi, ma'am, because nowadays, if you review the literature or if you look the guidelines about the handling of the such a non-edible substance or poisonous, still we are the so far from the making the proper guideline. Especially, I am talking about the alkali injection. Because after 2013 incidents, Lakshmi versus Government of India, that the acid attack, after that government make the very strict or firm guidelines about the selling of the acid. But I'm just before this session, I'm looking the various act and guidelines from the government side. So they only recommend the or control the selling of the like the acid or some of the poisonous substance, but not comments about the alkali. That the latest upgraded rules or guideline like the model poison possession and sale rule 2013, they give the two different annexer A that only oriented for the acid substance, and annexer B only for the poisonous substance. They are not that rule are not control the selling of the alkali. And in the majority of the emergency, we seen the cases that the accidental ingestion of the alkali. So, what are the role of the government to, or what is the role of the stakeholders or scientific bodies like the IAP to give the suggestions to our government or to make the proper legislation? And second, how to handle the anxiety of the parents as well as fear of the pediatrician, those who are sitting in the emergency and come such a crisis, come such a children in the emergencies.
See, as Dr. Vishwanathan said, the alkali most commonly are used for very common household
Yes.
kind of tasks, drain cleaners and those bleaching agents and all. So they are the ones which are routinely available in the household, though in small concentration. So one major thing is they are actually because of child, not neglect also, I would say in a way, because they are kept in the bottles which are routinely used for other purposes. So most commonly, which we come across for corrosive injury like alkali is that they mistook it for cold drink because they are in those Sprite bottles or those cold drink bottles. So one are those I would say intentional kind of ingestions which are because of the storage, improper storage at the home. And second, we have a lot many children with attempted suicides. I also made a student do a thesis. We have 70 cases in last 1 year of attempted suicides which have come to us, and there is an intentional ingestion. So if you talk of this, because I was very much concerned with the paraquat ingestion and the deaths we couldn't save, and all of them wanted from the very next day, all of them were looking at us that they wanted to survive. So nobody was going ahead with the decision of, that the things are not favorable and I really want to commit suicide. They did everything in impulsivity. So basically, what we have to now kind of control and make awareness in the schools is what the impulsivity, how to deal with impulsivity, and how these children have to be prevented from these kind of actions. Because I thought of, like you're talking of legislations, I thought of Paraquat had kind of drafted the mail to DCJ, everything I like wanted to do for, banning this Paraquat in the morning. Once I saw the 20th child and I was like, 3 months he's looking at us that we do something and the child expired. So this was my first take on this. But then later over the day, I realized that maybe this is a cheaper kind of insecticide, and many farmers would lose their, crops, and their children might die of starvation if I go ahead, because I don't know the cost benefit of such a kind of a legislation demanding it. So for us to kind of even ask for the balances in which favor is difficult. And finally, over the day, I kept on thinking, and then I realized probably if we stop one, and the ones who have to take, are doing it intentionally as a suicide attempt, then probably the impulsivity is something we have to stop, because we may ban one or two products. Ultimately, they'll find other options. So this is what we've started. And as a part of the Mohali annual, I took a lecture also on this suicide prevention and impulsivity control, how grounding techniques, breathing techniques, and all have to be taught. And it was a consensus of the audience that we need to take it to the schools and start, dealing with such issues. So it's only legislations probably will not be the answer. We have to tell our Gen Z and Gen Alpha how to deal with kind of stresses and how not to act impulsively.
So in the short, ma'am, any adolescent child come with the corrosive substance ingestion must be counseled by the child psychologist. But as a being pediatrician, if the any child above the 5 to 7 year older, the child should be counseled by the psychologist or pediatric psychologist to for the behavior or other things issues. Dr. Viswanathan,
Yeah.
as you told that as you told about the sticky barriers, that the like the honey, you rightly said about that the guidelines said if the patient stay in the remote area, that the incidents happen in the remote areas, before reaching to health center, they can give the honey. So there, definitely you are absolutely right that the recommendation that says, but any sticky barrier, either honey or any other edible food items like the restricted amount of the edible glue can be prevent the injury by the coating of the foreign body. But
Okay.
but as a physician, I would like to promote the use of the mucosal protective agent like the sucralfate, rather than these are the food, these are the home remedies. We are not too much have the scientific evidence about how to go ahead about the honeys or glues about. So it's better to use the mucosal protective agent like the sucralfate. The dose of the sucralfate is just like the 20 times of the weight. If the child is a 10 kg, just multiply 20. That is a usual dose for the per dose. So you can advise to twice or thrice a day. Just don't advise to swallow. Just lick the medicine. That is might be very helpful, and at least they can prevent the severity of injury of the mucosal tissues.
Again, emphasize to refer, not to delay. They can take, but they have to come to the hospital soon. Yeah.
In the my counseling, I always include don't believe on refer. First, do the tries, ABC oriented care, then pre-referral treatment in the corrosive or in the foreign body, just like the sucralfate is a pre-referral treatment. Then refer to higher center where the pediatric gastroenterologist is available. Then we can manage the child appropriately. Then from the last queries as a being pediatrician, because I seen the many children come in our emergency with the NG in situ. You rightly says that the no blind insertion of feeding tube in corrosive children, because rather than benefit, very high risk of the iatrogenic complication that might be create the medical legal issues. That you are absolutely absolutely right. But how can we handle this medical legal issues? Because many times in the case of corrosive injection in the private setup, they refer the child before without assessing the child or ABC care. So how can we handle this medical legal issues, or should we make the MLC of the each and every cases of the corrosive injection?
What do you mean by MS? You repeat, what did he? MS?
Medical legal MLC.
Yeah. Got it. So I think, as you rightly mentioned, I think the ABC has to be taken care before any referral happens. At least a cannula should be cited. The blood sugar should be checked. A, B, C, D, E, F, whatever it is. Making sure the temperature is fine, making sure the sugar is fine. We are saying not to give IV fluid, not to give NG, not to put NGT. We didn't say that not to put IV fluid. IV fluid can be commenced, not a problem at all. You can give IV PPI, you can do this. Yes, MLC depends, as Dr. Ruzi has already mentioning. Yes, if you strongly suspect, like adults and teenagers. But for these younger children, I do not think particularly, but you could. I think the MLC is more. If it's a country like UK, the MLC, those things are done to basically to make sure that the parents are taken to the task. They are not taken. They are not in supervision, etc., those sort of things. But here, what we are going to achieve by doing that is what we have to decide. That's the thing. I think sometimes when we do all those things, actually, we are not going to help the society. We should not delay the process of getting the child treated. So somebody can sort it out, but the process of getting treated should happen simultaneously. There should not be delay in that.
Okay. Some of the one of our audience says the kerosene injection need the endoscopy assessment.
Very good question. They don't come to me. They have not seen me so far. Well, they could. Most likely, that is basically they say chemical pneumonitis. But again, if the symptom, then you can consider. I think just for corrosive injection, I won't advise endoscopy unless there is a very clear history of GI symptoms. Yes. Or also check whether they're taking something else.
What is the advice for our fellows pediatrician about the long-term follow-up the post-corrosive, post-foreign body, and what is the at least minimum duration to child monitor for the subsequent complications?
A very good question, very good. Because, I didn't mention this during button batter injection. Even though the child has been stable, for example, button batter has gone into the stomach. Okay, button batter has gone to the stomach, but there has been delay in the patient presenting to you. There is always a possibility esophageal injury might have happened here. And usually we take ideally 3 to 4 weeks, definitely, because these children, not only foreign bodies are talking corrosive also, 3 to 4 weeks, definitely one review has to be done. Or earlier, if there's any problem and any significant symptoms, 3 to 4 weeks, they're okay. Usually the development of stricture is less. But having said that, you give the warning symptoms to them. If this happens, please do come to us early. But definitely one follow-up 2 to 3 weeks and probably another one 4 to 8 weeks. That will do most of the time.
Okay. What is the any particular advice for the anal foreign body?
But I think anal foreign body, I mean, if you have a very clear history, whether this has gone from the GI tract or whether gone from this route, we don't know. I think if it has been there for a long period of time, then you remove that. Otherwise, no need to worry. It all depends on the nature of the foreign body. I saw one question about something about the ileocecal junction foreign body. Sometimes, I had basically my patients, I'm just giving history, sorry about this. They told me they'd taken a key, okay? But what happened, there's a bunch of keys and there's a ring attached to that. One key is trying to come, the other key could not come because of angulation. So all this is a very important. They told us only one key, actually it's a 3 key superimposed on the image. When you're trying to remove, then we saw this is what is happening. So anal foreign body, any foreign body, it has been there for more than 7 days, more than 10 days, and it's not coming out, symptoms, remove that. It's easy to remove, nothing wrong in that.
Okay, this question for Dr. Rossi, because that post-corrosive, many of the children require the follow-up and dilatation of the esophageal or esophageal dilatation to re-stabilize the feeding practice. So that child regularly coming in the OPD for the repetitive endoscopy, how can we minimize the parental anxiety or trauma, because they have the repetitive visit, they have child require the multiple endoscopies in the follow-up for the dilatations?
I think it is basically counseling and gaining the trust of the parents and explaining them. And I think endoscopists themselves also do the needful, and they show them through the videos as well. Like, in angiography, they show this much is the blockage. So they clearly show them in MRI, brain and all, they don't actually see the lesions. But here on a video, when the endoscopist is doing it, they definitely show them, and they are mostly in unison with us, and they actually feel, that this is required. We've never had this kind of a resistance from them. They do follow the instructions and do come regularly. We also had children who required feeding jejunostomy. Also, the injuries were so bad, and but most of them, I don't feel that resistance goes. I think in the initial phase, if you develop that doctor-patient trust with the patient as well as the parents, then usually the teamwork of the pediatrician and gastro endoscopist does the job.
Okay. Other questions, that the role of the antibiotic and steroid. So I can conclude that the no role of the antibiotic or systemic steroid in the corrosive injection. So don't give the hydrocortisone or dexamethasone. That the no scientifically proven role in corrosive substance. Dr. Dinesh, because our secretary is not only MD pediatrician, he is also a qualified advocate, because he recently did the LLB. So I have the one question to you.
Yes, sir.
Because majority of the cases in the corrosive injection, as I am doing working in the government setup, many cases referred without pre-referral treatment in the private. They have the fear about the MLC case. So how can we handle without any minimum fear or anxiety of colleagues or physician? Or what is your message for the handling of these cases by the doctors?
Sir, actually क्या है कि the only thing is the documentation. So whenever you receive a child in your emergency, whether it's a referred child or you are first receiver child, the main thing is the documentation. What is the poisoning? How far away it was taken? Who have brought the child to the emergency? And what is the content of the poison? Everything you have to inquire and you have to document it. It should not be hidden. And then you make the MLC. If already MLC is made in some other center, then you take the carbon copy or the photocopy of that MLC and attach with your
So
documentation.
you want to say all are the corrosive cases must we make the MLC?
Yes.
Yes.
Every
It is a
case.
clear-cut message to our
Yes.
pediatrician. If you are
Yes.
dealing the case of the corrosive injection, you must be made the MLC and give the first aid treatment before to refer.
That is the only legal shield you have. Only legal shield a doctor have the documentation. You can fight the case in the court only with your documentation.
Dr.
Okay.
Dinesh, the child is brought in.
Yes, sir.
Sir, your voice.
And as I was hearing Dr. Meena also, after
The child is
2013
brought
case,
into the OPD of a clinic.
yeah, sir, you're not audible. Hello. So
The child is
Delhi
brought in the
government-
OPD office.
Yes, sir. In OPD also. as per the national NMC guidelines, you have to give the basic care to the child and refer to the nearest center for the proper treatment of the child.
Any MLC, can we make an MLC or we
Yes,
inform the
sir.
police, or should we simply inform the police?
No. First you made the MLC, then you inform the police.
Normally, we
Otherwise,
do not carry any MLC register in the OPD.
sir, if you are treating a child or you're giving the care of any poisoning case in your OPD cases, then you have to make the MLC in OPD also.
Okay.
Or
Yes.
if the parents many times deny to make the MLC, in that situation,
Yeah,
you
in
can
that
take
scenario,
the,
you take the written consent from them.
you
We do
can
not
take the
want any
written
MLC in
consent.
this case.
Yes. You can take the written consent on the
Yes.
OPD slip, and one of the copy of the OPD slip you must be kept to your side.
Absolutely. Acha,
And
I have shared the acid patient guidelines of the central government in delegate group also. And after 2013 case of Lakshmi, the Delhi government also made a rule of Poisoning, Possession and Sales Act in 2015 also. So you can go through that also. And the only legal shield for a doctor is the documentation. That's it.
thank you. Last question for Dr. MS Viswanathan. Sir, does any correlation about the amount of the substance ingestion possible injury? Because many times even in my wards, my resident says that sir बच्चे ने तो only slightly एक ढक्कन पिया है, कुछ नहीं होगा. How you take it?
I think let us not break our head about amount taken, because, and as Dr. Rusi was mentioning, paraquat itself is coming in 2 different strengths. I don't know whether you know it or not. Higher concentration is also available. So it doesn't matter what the amount is taken. The symptoms is what is very important. I think if somebody asks about the question, don't worry about it. I think we need an assessment of the ABC, DE, whatever it is, and an endoscopy.
And
if the child is stable.
Suppose child not have the history of the corrosive ingestion, even acid ingestion, but not have the local injury or local trauma in the oral cavity. Should we take light?
As you told earlier, no. Whether it's an acid or alkali, whatever it is, I think if there is a definite history of ingestion, they need an assessment. I tell you one important thing. Why we have to assess? No, this stricture happening after corrosive is a nightmare to treat. I'm telling you, for both of the patients, parents, and everyone. So it's very important to identify this problem early, define the grade of the injury, and then reassure the parents or ourselves, so that I think it's always better to just do once and then just leave the headache.
Here, clear-cut message to our participant or our audience. No any correlation between the amount of ingestion and possibility of injury. Any child have the history of corrosive ingestion should take very seriously without even in the absence of the local site injury.
Yeah.
Thank you. Over to our president or secretary, sir. Dr. Karnesh, I think Dr. Karnesh here.
Yes, yes, Dr. Karnesh.
Dr. Karnesh, I think. Thank
you, Dr. Meena, for wonderful coordination of this session. We are thankful to Dr. Viswanathan sir, Dr. Rosie Olak, and Dr. Anurag for the session, and we thank all the delegates for joining in. I request Dr. Dinesh to please conclude the session.
Yes, sir.
Just one comment, if you don't mind. It's
Yes.
a very wonderful
Yes, sir.
initiative by the
Yes, sir.
IEP team. I want to appreciate Dr. Meena and Dr. Karnesh for putting nice topics together. Very wonderful educative, what to say, step. Thank you very much.
Thank you, Vishwanathan sir.
Yes, sir.
Such a
Thank you for the
wonderful, lucid talk and very, very informative sessions. And our aim is to percolate your knowledge, the experts' knowledge to the youngsters, the delegate PGs, and practicing pediatricians. We have to just update ourselves. We are not here to teach anyone. We have to just update ourselves and just skill the common pediatrician, so that we should not do a wrong treatment. We should not stuck in some legal hurdles and all those things. So your talk is absolutely fine. बढ़िया, एकदम first class. जिसको कहते हैं पंजाबी में एकदम सोनी talk.
As expected and always happen with Dr. Viswanathan, his talk very impressive, very practically and very useful for our fellows pediatricians.
And you are a very good orator also, sir. Congratulations to you. Now our treasurer cum secretary like Dr. Ravinder Kumar is with us. Welcome you, Dr. Ravinder, and please give vote of thanks to the all delegates and faculty.
Thank you, Dr. Dinesh, and good morning to all. Thank you, IIP Delhi and Dr. Sham Meena for taking this legacy forward. And I just want to extend my sincere thanks for this outstanding, actually, webinar on foreign body ingestion. Actually, I have listened to many of the content, and it was very exceptionally informative, highly relevant to our OPD practice. And content was delivered with so much of clarity and practical insight, which is very, very useful for our OPD practice. So thank you, Dr. Vishwanathan, and thank you, Dr. Roji, for a very clear picture and very clear content. Thank you, Professor Anurag, for always be there. Thank you all. Thank you.
Thank you.
you, team IIP.
Nice to
Thank
see
you,
you,
everyone.
Dr.
Thank
Anurag.
you.
Thank you so much.
Anurag.
Thank
It
you,
was
madam.
nice,
Thank you,
informative
Anurag
session.
boss.
So please join next week. This
Thank
time,
you,
9
Shyam
o'clock.
boss.
Thank
डॉक्टर
you.
अनुराग सर कुछ कह रहे हैं?
Chalo, bye bye.
Bye sir, bye.
Yeah, it was a great
Yes,
session and I enjoyed it. And
yes,
medico-legally, I just wanted to add that if the child is sick, you need to transport the child with you to the hospital. You simply
yes,
cannot put him in the ambulance and let him go. That is what is the latest BNS Nyaya Sanhita, Bharat Nyaya Sanhita is saying.
yes.
That if a child is sick, is collapsing, then even the doctor who's sitting in the OPD will need to accompany the child to the nearest hospital.
Yeah, transport is
Other
very
than that,
important.
I think it was a very
Yeah,
informative
yeah.
session.
Nowadays,
So we have to
everyone.
understand that.
Yes,
Yes.
yes, sir. Yes, sir.
So we have to understand that transportation of a sick child is the responsibility of the first contact physician sitting
Yes,
in any commercial place, but not his residence, but if he's sitting in a clinic, he has to have the facilities of first aid with him.
yes. Network poor है sir. Yes.
ठीक.
Okay. Thank you, everyone.
Okay, sir. Bye, sir.
Thanks
Have
you
a
all.
good day, sir.
Thanks you all.
Have a